Well, good afternoon, Dr. Clifton Bingham. We are so happy you're here from Johns Hopkins University in the United States, in Baltimore. Folks, this is like one of the world famous. We rolled out the red carpet to get you in here, Clifton, and we're very appreciative that you've come by at a very busy time. I know you have a poster to go defend,
right.
So we're gonna get some super duper knowledge out to our audience very quickly and let you go do your thing. You're a rheumatologist, been practicing a long time. You do research. Some of it's very clinical, kind of applied with patients, like patient-reported outcomes. But you're here to talk about something very specific, very important, and that's what happens when you're treating patients with cancer and they go on to develop some type of rheumatic disease.
Right.
Yeah, so, okay, that's the limit of my knowledge, folks, and now we're going to turn to the expert. So tell us what you're going to talk about.
Yeah, so a few years ago, the oncologists started using a new class of drugs that are called checkpoint inhibitors, or immunotherapy. These drugs work by turning on your body's own immune system to fight cancer.
Okay.
What's been happening with these drugs, though, is they're incredibly effective for many, many different types of cancer, including melanoma, lung cancer, various other forms of cancer that had previously been very resistant to therapy. But as a consequence of turning up the immune system, we're starting to see new immune-mediated diseases that are developing in patients.
And they are diseases like mine, rheumatoid arthritis.
Diseases like inflammatory arthritis, vasculitis, polymyalgia rheumatica.
Wow.
So a whole spectrum of our rheumatic diseases that we're seeing.
So a patient with cancer goes in, is very excited to get their cancer very effectively treated, but end up with a chronic disease.
Right, so the unfortunate thing is that about 30% of patients that we're finding now go on to develop a chronic form of especially inflammatory
That's quite
arthritis.
high.
It is,
Yeah.
And so of all of the patients who receive these drugs, somewhere around 5% of patients will develop some rheumatic adverse event.
Right.
And then from those, about 30% of those cases will go on to become chronic.
Okay, so not a crude 30%.
No.
Okay.
A crude 40%, though, of patients have some immune-related adverse event that may not be rheumatic in nature, but it could be related to thyroid disease, related to colonic inflammation or lung inflammation.
Okay, so then, as a result of this, super duper stimulated immune system because of checkpoint inhibitor treatment, they get this rheumatic disease of some type, one shape or form. Does it have chronicity? Does it with you? I mean, I was diagnosed. We have no cures for my disease.
Right.
I've been on treatments which, touch wood, have been fairly good for me. Do these patients who have cancer where this occurs, do they have the same type of disease?
No, the diseases are different. And
Okay.
that's one of the things that's really interesting from us from a research perspective, is trying to understand the differences between a normally occurring rheumatic condition versus these that are being caused specifically by a drug.
Right.
So we're beginning to appreciate some of the nuances and the differences between what would be a usual case of rheumatoid arthritis or a usual case of psoriatic arthritis.
I see.
Versus the sort of the cases that we're seeing from the checkpoint inhibitors. But in terms of therapy, it's one of those things where a group of patients, all they require is a little bit of steroid to be treated, a little to a moderate amount of steroids.
Yeah.
And then as the exposure time from the checkpoint inhibitor lengthens, many of those people will go into remission and their condition will go away.
I see.
But it's an unfortunate about 30% of the patients are going on to develop chronic symptoms.
And so they're going to go on to a DMARD or a targeted small molecule or something like that.
Right. And when we think about that, that introduces a whole lot of other considerations, because the medicines that we're using to turn on the immune system to fight the cancer, we don't want to downregulate them too much, because we don't want the cancer to come back.
Yeah, and the things that are used in my body are meant to blockade or resorb which is an oxymoron in treatment, really. Yeah.
Right. So the conversations with patients...
I don't envy you your job, by the way.
No.
Yeah.
The conversations with patients can be very difficult.
No kidding.
There are a lot of considerations, and then we work really closely as well with the oncologist and with other specialists who are dealing with the other consequences.
And now rheumatology is in that conversation too.
Absolutely.
Yeah, because you can't leave patients sort of not knowing about this.
Right.
These are real risks, and you're meeting it head on, which I think is the way most patients, if they're well supported, and understand it, have an educational background to grapple with it, or someone who can effectively translate for them, they can make an informed decision.
Right.
Yeah. Well, super important work. I learned about checkpoint inhibitors actually at last year's Canadian Rheumatology a little bit, but this has really been super enlightening. We wish you well in your work and want you to come back.
Thank you very
We
much.
have a bit more time with you,
Okay.
but we know you got to rush off. We really appreciate it.
Thank you very much.
Thank you so much.